afternoon, everybody. My name's Howard Catton. I'm Head of Policy and International at the Royal College of Nursing. I'm going to try it from here, but if I'm in the way, just shout and I will move out of the way. As Simon said, very, very timely, obviously, 6th of January, the NMC have officially launched part 1 of the consultation on revalidation, which is due to run for the next 3 months until the end of March. We think there's going to be about a month's break, and then there's going to be another consultation on the code. But just to confuse things a little bit, there are some code-related questions in the first 3-month consultation. Just to be clear, what I'm going to try and do is to set up what I think some of the issues are that we need to be thinking about, and some of the questions that we need to find answers to. But I'm not going to be setting out anything which is definitive RCN policy on what the future of revalidation should be. And the very simple reason for that is that we are also going to be consulting with members, and our council, our member-led executive, will sign off a formal response at the end of March. And if I do anything to suggest as a member of staff that I have determined what RCN policy is, I wouldn't be here as a member of staff at the RCN for very much longer. That said, I'm going to be as candid as I can be about what I think some of the big issues are that we need to address, because as well as the mechanics of what revalidation does or doesn't look like, I think that there are some big questions as a consequence about what we think we are as a profession, and how we want to organise as a profession for the future as well. In terms of what the RCN has said on the record, just to be clear, we supported the Francis recommendations. We said PrEP isn't working and we need a new system of revalidation. So we have said that we think the system needs to change, as indeed have lots of other folk. We have said that we don't think that the change should result in any fees increase to registrants. And we, and a number of other organisations, have said that as well. But we have not agreed any of the principles that the NMC Council have thus far. So the NMC Council in September or October last year agreed that there would be a consultation, and they agreed that their favoured model was one which would include some forms of third-party feedback, and we'll talk more about that. But from the college point of view, we said yes, it does need to change, but we haven't got into prescriptions about what that should be. This as a topic, I remember when I first started with the RCN, you were pretty much an anorak if you were interested in regulatory policy. So let's be frank about it, geeky sort of a subject. And I think the world's changed hugely over the last year or two in terms of regulation. When the NMC Council took their decision that we needed to introduce a system of revalidation, if you'll remember, it was headline BBC News. It was couched in MOTs for nurses. But on the back of Francis, on the back of the big questions that the profession has been facing about, is it broken, has it lost its care and compassion, revalidation in terms of public consciousness and awareness and media debate and discussion has gone right up the agenda. And even last week, the Professional Standards Authority released their report where they'd looked at 100 fitness to practice cases from the GMC, and where they thought things were going well and not, and that again attracted me to say. So this is a much higher profile issue. I think there are very good reasons for that, but that's different from before. I also think that revalidation for the profession, I'd have it in my top 3 for issues for the profession for this year. And I think I'd also say that I would see this in the context of, this is a I think this is a seminal year for the NMC. This is the year that the NMC will come to the end of the 2 years of, it's not officially called special measures, but the improvement programme that they were set out to deliver on by the Professional Standards Authority. That concludes this year. There will be a report in a few weeks, the corollary to the GMC 100 fitness to practice cases. The NMC one will be out in a few weeks' time as well. Plus we've got revalidation. And there's a new council and a new leadership at the NMC as well. And this is one of those comments for discussion and debate, but and I'm not saying that this will happen, but just in the spirit of this sort of discussion, if we get to the end of this year and significant progress hasn't been made on fitness to practice, the number of revalidation doesn't seem to be working, there are still financial questions. I wouldn't be at all surprised if increasingly the debate is, do we need to do something fundamentally different with the regulation of the profession? I'm not saying that will happen, but I'm saying that's why I think it is so significant when you look at what is in store for regulation and for the NMC this year. And I also think it's interesting within the, you'll have more incisive views than I on this, but if one looks at what's happening across the service in England more generally, big debate I think you're starting to see play out now is the system is health services over-regulated, the CQC debate. Those of you who must follow, some of you must follow and read Roy Lilly's daily, weekly blog, and he's picking up that theme. So, and we shouldn't see professional regulation as separate and divorced from health systems regulation. I think we need to think of them. We need to think of them together. There are memorandums of understanding, as you'll be aware, between NMC and CQC, and we can talk lots about that, but I won't. There are clearly very good reasons in terms of the sharing and learning that the regulators talking together can do. So that's quite a lot by way of introduction and thoughts and context, but I think those things are there. So just in terms of purpose of revalidation, I just try to capture on here from, if you do a cross-section of any of the reading, they all point out that purpose of that clearly in terms of patient and public protection. There's a lot said in France as well about not only public protection, there's other issues about public and patient confidence. It's taken quite a significant knock, and this is part of both protection and confidence for patients. But we should never forget that it is an individual registrant responsibility to stay up to date and to be able to demonstrate how they're staying up to date. And we should never look as though we're shirking that individual responsibility. But there is also, and also, revalidation says something about the very nature of a profession. It defines what a profession, what a profession is as well. And if you get all of that right, if you've got individuals and you've got a profession learning, reflecting, critically challenging, thinking of new ways to do things, the payoff and benefits in terms of the sort of culture that infuses, that leads to develop, is the sort of, I think, starts to get you close to the sort of cultural changes which Francis and lots of other people are saying is absolutely the heart and crucial of what we need to do for health services going forward. So important to see revalidation as much more than just the individual. This slide, busy as it is, but it does just in one place put up for you what the key recommendations on revalidation were from Francis. 192 talks about a system of revalidation that included the concept of a responsible officer medical model. I'll say a little bit more about that in a moment. I don't believe that there is any appetite at the NMC to introduce a similar responsible officer model for nursing, but I think we as nursing, as a profession, as Simon said about medicine as well, should absolutely keep our eyes and understand and learn from what medicine has done, and the sort of still in the piloting phase of that. Others will know better than me. Also the costs of that as well. Recommendation about minimum standards for appraisal. I'll say some more about appraisal because there's big issues about the use of appraisal. Issue around feedback, evidence by feedback from patients and families. This probably emerged as the immediate hot issue when I was starting to talk about revalidation with groups of members in terms of what sort of feedback was appropriate, and you know, things like, well, if I work in theatres, the patients anaesthetised, if I'm given a box of chocolates, that sort of debate and discussion, as well as people thinking about whether there are ethical considerations as well. And a big issue about countersigning and sign-off, and this is one of the issues I think for me which takes us into the broader professional issue and what we want to see. If as a registrant, your feedback and evidence is being signed off, is it okay if it is a non-registrant who signs that off back to the NMC? Question. I think the question that particularly for nurse leaders who the person doing that might be a chief executive or somebody, then a very real and live question. You might think this slightly odd that I put up something about the NHS Constitution, but I just want to. I think it's important just to be aware, just to be aware of it, because there are links and it fits with the whole values, attitudes, behaviour debate that we've seen play out. Very important over the last few months. A lot of folk who think that it's just a toothless tie with the Constitution, a lot of fluff and warm words, but that doesn't really mean anything at the shop floor. There is going to be a refresh of the Constitution, and more's likely to be said about that in the coming weeks. But I think there is no doubt that there is a very genuine desire from the top of the service, both from the political and from the managerial side as well, to do much more to embed constitutional values within day-to-day practice, within things like appraisal, and within contracts of employment as well. I'm not saying that I'm saying it's something that I support, but I think that just as a demonstration of where people want the Constitution to have much more life and breathe its way through the service. But the work which is being done, and this is the link here for me, the work that's being done on attitudes and behaviours and the Constitution, seen as linked up to work which employers are leading on appraisal and performance management, and therefore if we're using appraisal and performance management systems for revalidation, what might some of the issues be? For the very simple reason, which you all know, that if it's a process of revalidation, that's about being fit to practice, whereas an appraisal process is about fit for the job. So it might be, some people might say, you're not fit for your current job. I have to be a registrant to be this job, but that doesn't mean I'm not fit to practice in another role. And I think there's some tricky stuff we need to unpack. So just in terms of a starting point, and I think I've flagged some of these already. Individual responsibility, we should never try and shy or get away from that. Employers and managers do have a crucial role, undoubtedly, but exactly what that relationship and what that role is. There needs to be a strong relationship between the professional regulator and leadership throughout the NHS. But what exactly does that look like if it isn't the responsible officer? Francis talked about, floated the idea of employment liaison officers. Realistic and adequate resourcing is needed. I'll say a little bit more about that in a moment. It mustn't be overly bureaucratic, and of course it must improve patient safety and quality. And if you didn't know it already, hence why one starts to get a feel for just what a tricky job and complex job this is going to be over the coming weeks and months to design to design a system which deals with all of those issues. So let me say a little bit about the link between appraisal and revalidation. Obviously, talked about fitness to practice, being fitness to do the job. But I think, and I've got some statistics for you, Megan, I think there are very, very real issues about how many people do get appraisal. Most recent staff surveys, NHS staff surveys, put it around about 80%. I think from 11 to 13, it had gone from about 80%, it's done over 2 years, as you know, from about 80 to 83%. So that's good, but there's still, 17, 20% of folk who aren't getting appraisal. And there are differences in other sectors in terms of appraisal. And then there is, even if you're getting one, is it any good? And I've got some stats on that as well. And I think there are some big issues on CPD spend. From some of the work that we've been doing with Health Education England, and I'm, without getting diverted onto other things, Health Education England, we've been working closely since they've been set up. I'm really very encouraged by the sort of direction we're heading in with Health Education in England. You would say that, wouldn't you? I hear you think, seeing as they just announced a 9% increase, or at the end of last year, a 9% increase in pre-reg education, nursing education places. And that is positive, but I think that a lot of what I've seen come out about Health Education England in terms of thinking about whole workforce, both medical and non-medical, thinking about how workforce joins up much more closely with how service is delivered, gives me some optimism for the fact that we might at last be able to move from the torrid history we've had with workforce planning. I don't want to give them the clean but too quickly, but it does feel it's moving in a positive direction. And one of the discussions we've had with them is if you just look at medical and non-medical spend on CPD, I've seen some LEPs who spend 60% of post-reg monies on medical and non-medical, and some of the national, if you look at the national figures as well, it looks around 40–45%. I think there's a big issue about the totality of CPD monies and how they're split up and how they're shared between different professions. And I'm not saying that to try and start a fight with anybody, but equally, if we're going to have a very, very serious debate about appraisal and revalidation, then the money's important. It says something about inconsistency of appraisal processes. I think you may be aware that as well as the NHS staff survey, the RCN runs its own survey every couple of years. So it's a survey of members, and we ask some more detailed questions about personal development, training, personal training and development plans, and our most recent survey showed that we had, you can see 38% of nurses who hadn't received any CPD provided or paid for by their employer. It doesn't mean they're doing it a lot on their own, picking up the tab for themselves. An issue with older nurses, less likely to receive CPD, 55%. I think there are a set of issues in here about, as a profession, we're ageing, pension changes, folk are going to have to work longer. I haven't got any hard and fast stats on this, but from the stuff that we do see in the college, there seems to be a risk that as you get older, a referral to the NMC for an FTP issue may go up. We need to do some more work on that. And if that's the case, then I think there might be a relationship in terms of access to CPD and support that nurses are getting later on in their career. And clearly there are issues for the fact that we are ageing as a profession. These are some stats from the RCN survey. And I put these on so that they compare 11 and 13. Our survey is based on about 6,000 RCN members, so it isn't the sample size of the NHS staff survey, but 6,000 representative sample is good in my book. So, did you have CPD provided or paid for by the employer over the last over the last year, and we've seen a jump from 28 to 38%, from 11 to 13, and nobody had none at all. 1 to 2 days is holding firm around about a quarter, but then for all of the rest, the numbers it's got worse within those last two years for all these other categories of days or weeks. So there's clearly an issue there. The personal training and development plans. These are the issues that I raise in terms of differences between settings. Do you have personal training development plan by sector? You've got differences in the year here, but interesting to see in your hospitals, GP, community, NHS settings is up here at 60 to 70%. Independent hospitals and charitables are around 40-50% in the middle, and then independent sector, care homes and bank and agency are towards the bottom. There are, I know, some big differences between individual organisations. So I am not wanting to suggest for 1 minute that I'm painting all independent sector hospitals as good or bad, or equally, or NHS hospitals as good or bad. But on the basis of the survey, there are sector-wide differences. This, I think, is also important in terms of thinking about when the NMC work gets to a place that we think that something's starting to emerge about what the system of revalidation will look like. It's going to be piloted. They're committed to some piloting work at the end of the year, and they've talked about the fact that we need to. With part of the discussions we've had them as well. Clearly, we need to think about making sure that we pilot across a range of settings, and I think this will be important to try and pick this. Clearly important to pick the different settings up in terms of piloting, so that we don't end up with a model which we think sort of works okay for traditional NHS acute, but which is way off the mark for everywhere else. I also have a question in terms of you know there's lots of discussion about also, and this will be to do with the auditing of whatever system emerges. How the NMC audit that, and people rightly, but it can sound slightly hackneyed, talk about we'll take a risk-based and proportionate approach, which means that some of the higher risk areas, I think, are what people who are working on their own, people who may be working with some highly vulnerable groups. I wonder if there is also a question in terms of advanced practice for the profession as well. If you think some of our colleagues are working in advanced practitioner roles and the way in which they've extended their role, but the level of risk that there might be, then certainly I think the piloting system needs to make sure that it's fit for people in advanced practitioner roles. And that would, in a different forum, might here lead you to a discussion quite quickly about whether we should be looking through revalidation from a professional point of view to look at having some system of recognising advanced practice within the new regulatory arrangements and the revalidation system. And you could certainly present some arguments for that, but equally we have to go back to the not overly bureaucratic and burdensome, the cost issues and the logistical issues of doing that. But I'd certainly be interested in hearing people's views on that. And then this is interesting in terms of whether you engage with your manager or not, in terms of your personal development plan. Again, you can see there are differences between different areas, but I think significantly a quarter, 20-25% are organised who said to us that they don't engage with their manager at all. The other interesting dynamic influencing factor that we may well have to think about this year, as well as what appraisals are used for and whether your manager's involved or not. Pay is going to be a big issue this year. It's setting up already in terms of, we thought there was a commitment in the NHS for a 1% increase, and there's been very strong noises from George Osborne, the Chancellor, that shouldn't be the case. You know that there's a lot of chat about automatic implementation and whether pay should be more closely tied to performance. So the potential that if we're using appraisal systems, and I'm not saying this is a reason not to do it, but just in terms of the issues to think about, we're using performance appraisals as well as stuff about sign-off and whether the registrant is, whether that's through a registrant, the potential for appraisal decisions also to have an aspect to them which are about pay as well, and is that sort of cocktail that would, you know, that can work or should work, and what are the risks associated with that. I said I'd say something about the GMC model. I only came across it towards the end of the last year in terms of any evaluation work that's been done of the GMC model. There's a report from the King's Fund, I can reference if you want it, from some evaluation that they did in London. Another slide to share some of that with you. So you know, Revalidation has been statutory adopted since 2012, led by the GMC. Appraisals are key. There's a responsible officer role, but the responsible officer is a medical registrant, and every 5 years the RI has to make recommendations to the GMC on individuals' doctors' revalidation. The King's Fund report, these are the key findings from the King's Fund report, October it was. Firstly, it works best where you have the organisation behind it, where you have the right culture, where you have a robust system of clinical governance, where investment in staff is prioritised. Those are the sorts of organisation where, for medics, this is working best. The link between the organisation and the regulator, and strengthening the link between the organisation and the regulator, has been seen to be a positive benefit that's come out of the work that's been done so far. They are still working out what meaningful feedback is, and they felt that there could be the process could be strengthened by focusing more on the quality of the appraisal process, which is interesting in terms of some of the issues that we've just flagged up in relation to appraisal and nursing. This quote, it's from their report. This quote struck me from the King's Fund report. Each employing organisation has to appoint a responsible officer who has a statutory responsibility to ensure that they have robust systems of appraisal and clinical governance in place to support the process of revalidation. This role is critical to the success of revalidation and makes the formal link with the professional regulator of the GMC in this case. So it is whilst it's work in progress, and there is this learning in terms of a role that links between the regulator and the service, absolutely seems to be highlighted as being crucial. So some final thoughts, and I'd say a little bit about what we're doing as a college in terms of consulting with members. Big issues around what feedback can be used, what should be used, and how do you describe a system for feedback which works across a range of different settings, and for those who might be working in traditional settings. How do you address the issue of quality or inconsistent appraisals? I think a big risk for the NMC in terms of if they prescribe a system that they then have no direct control over. What levers do they need? And in terms of the resourcing, the NMC Council paper said that they had £5 million to develop the system, and they anticipated that would be £1 million a year running costs. There was a Nursing Times report who ran some numbers and said that they thought we were looking at introducing a system for nursing which came in about £1.50 a head, and Nursing Times HSJ did a similar calculation for medics and they came up with a £6 a head figure as well. It's not always about the money, but money clearly is a very significant issue. In terms of the consultation that we're doing, and I'll close it just to say something about what we're doing as a college. We want to encourage our nurses generally and RCM members to respond directly to the NMC. So there's a 60-question consultation. 20 of those you'll have seen, I think, to do with who you are and where you're from. So, but it's significant. We don't want to detract people from filling that out and letting it. It's the NMC's consultation. People need to tell the NMC what they think. But as I said, we will be putting in a response to the college. And what we've already put out papers to our governance structure, like our boards, our regional boards, our country boards, our professional forums, our activists, one for our students as well. And the issues that we're asking them to focus down on are what we think probably some of the hot issues, or some of the hot issues are. And again, whether we've got these right or wrong, equally I'll be very interested to know view. And I've touched on it. So feedback. What sort of feedback, both quantitatively and qualitatively, is legit, is reasonable? Should we be looking at? In terms of sign-off or confirmation of that feedback, of that evidence, who can that be from? And that's the questions about, would it be okay if another registrant, if there was no other registrant in the link there at all? The issue about appraisal, should we be using appraisal, and if we should, how should we be using appraisal, what would we look for? Issues about where we think the biggest risks are in terms of setting and in terms of roles and jobs. A question about what we think the relationship between the professional regulator and employers should be. Do we need to do anything for that to strengthen or not? I touched on some of those things. And then finally, a question about what sort of audit system will the NMC need to have in order to make this credible for the profession, because clearly PrEP and a handful of fire portfolios which have been audited are no incentive. That in itself is no incentive for people to stay up to date. So we are. Those are the sorts of issues that we're focusing down on in terms of wanting to get a view back from the membership. And that, as I say, closes at the end of March. We haven't gone over the top on the code because there'll be another consultation on the code, and I think it depends what the system looks like about then thinking about what the implications might be for the code. And again, I'm making sure Dan explains, but the feedback I hear where others are on this one, the code seems to be, we think that's a pretty good document. Probably one of the better things, in a few not one of the better things that the NMC do. So, there we go. I've tried some food for thought anyway to send you off. Brilliant. Thank you very much.
Thank you.